Dear colleagues and friends, it's my pleasure. Thank you for your interest in advance. Okay, I will speak about the vascular percutaneous approach for different kinds of aortic procedures, endovascular intervention for AAA and also for thoracic and aortic arch. With emphasis on totally percutaneous approach. This is our activity during the last year, our aortic activity increasing. So you see for 12 years we have done 775 aortic interventions on different levels of the aortic vasculature. And we have implanted to provide the percutaneous vascular access, we have in fact used 1,327 devices in order to make the percutaneous closure of this vascular access. Especially for the TAVI, we are using the totally percutaneous approach since 5 years. And we have compared the totally percutaneous approach to surgical approach with definite advantage of the totally percutaneous approach regarding hospital stay, blood loss, stay into the ICU. So definitely in favor of the totally percutaneous approach. There are many advantages of the total percutaneous closure. This recent systematic review of vascular closure devices for femoral artery puncture site is showing definitely that is decreasing not only the complication, the BEC complication rate, you are going to see what I mean under BEC, and also the patient ease and patient comfort. But to be fair, in order to provide in nowadays a totally percutaneous approach, we need definitely a closure device. So otherwise, it's not possible. This is our protocol. In most of the aortic procedures, we are using the radial artery in order to make angiography. So we don't use contralateral femoral almost never in order to have the pigtail on the right side in the right place in order to have the possibility to perform an angio in any single moment of the procedure. And more than obvious, we are using just manual compression for the radial artery. We are using sometimes when the target zone is far away from the upper approach, we are using brachial artery in order to shorten the distance. In this situation, in case we have more than 7 French, more than 7 French approach, we are using or angio-seal or ProgLite closure device. In the subclavian artery, we prefer subclavian and carotid with direct carotid access. Hopefully tomorrow you are going to see a direct carotid access for aortic arch pathology. We are using the stitch-based approach, ProgLite or ProStyle closure device. For the contralateral femoral artery in EVAR situation, we are using or angio-seal up to 12 French, it's off-label, I have to say that, or MANTA. And for the main approach for EVAR, we are using or 2 ProgLites in a perpendicular fashion or a MANTA closure device. Like Professor Trendafilova mentioned already, the key of success is planning. So we have to have the CT and the proper angio in order to make the puncture, like shown here, to make the puncture over the common femoral artery, so above the ligamentum and above the bifurcation of the femoral artery. And the best target, no doubt, is on the this zone that is over the femoral head, in order to have, even in closure device, to have the possibility for some compression sometime in order to facilitate the blood loss. So these are the possible considerations and obstacles. This can be significant and diffuse atherosclerosis, focal stenosis within 2 centimeters of the puncture site, a pre-existing or procedure-related vascular complication, vascular access obtained through a vascular graft. In this situation, manual compression is almost useless, so we have to use a closure device, tortuous tissue puncture tract, or twisted or bent procedure sheet. So several examples of what I'm mentioning, and what can be, unfortunately, the result of not keeping in our mind these possible obstacles and how to overcome them. I'm starting by historic point of view with the AngioSeal. That was one of the first plug-based closure devices. So there are, in fact, 2 plugs. One is inside of the artery on the vessel wall, and one plug that is connected to the inner side plug is connected to the outer side plug. And on such a way, like in ASD closure device, the vessel wall is between the 2 plugs that are connected with a stitch. So this is so simple. You can think it's so simple, but you know, the genius things are simple. So there are 2 versions, 6 French and 8 French AngioSeal closure device. And what I'm mentioning, this is the principle. So sugar, polyglycol carbonate from inside, and coagulation in inducing collagen sponge above. So both of them are totally bioabsorbable. So after 45 days, we can even puncture the same site, the same artery on the same site. So this is the collagen, and this is the anchor, the plug. So this is the principle of inserting, and several pictures. I mentioned already, you saw on the picture, there are 6 French version and 8 French version. But to be fair, in the practice, the 8 French version can be utilized up to 12 French puncture, and especially using the so-called step up and step down approach. So in case we have to put a 12 French sheet, we can go with 6 French, 8 French, 10 French introducer, and finally 12 French, in order not to lacerate the artery, but just to open the hole. And before implanting the closure device, we are going step down. So from the 12 French, we are going 10 French, compressing, 8 French, compressing, and finally put the plug-based closure device, that is the AngioSeal. And this is in fact demonstrating the re-stick. So what I mentioned already, that the absorption of both components, it's totally done in about 42 days, like seen here. And in 90 days, it's absolutely possible with low complication rate to puncture again the same site. And this is very important, that it's possible to use such kind of closure devices both for retrograde and antegrade puncture of the femoral artery. FemoSeal, it's very similar. It's again based on the same principle. The FemoSeal, and the size, it's again the vessel wall, the anterior vessel wall is between the anchor and the plug in order to heal after the implantation. And these are the hemostasis and event complication rate. We are going, let's say, next step. Next step is the stitch-based closure device. Like the Perclose and the ProGlide, it was the Percusurge back in the history, but the principle is the same. So to make pre-close with the stitch not tighten, and we are tightening just the stitch after finishing the procedure. So after positioning of the wire and positioning of pre-closing the artery, the target artery. I mentioned already this target artery can be the femoral, the brachial, the carotid artery, the subclavian. We are using quite a lot for the subclavian closure device, and this is the last version, the Pro style, that is facilitating, in fact, to externalize the stitches, the both sides of the stitch outside of the femoral artery in order to have the possibility to make the final knot and to move the final knot over the artery. Okay, this is the real-world evidence on repair of the large bore arterial accesses. I already mentioned that it doesn't matter if the procedure is TAVI or TAVR or EVAR. When we are using a large bore devices, we have to use, for example, two proglides to pre-close with two proglides on a perpendicular manner in order to have stitches in two perpendicular planes in order to close the artery. So this is the video, but I will shorten the video because it's very well shown on this cartoon. What are the steps? So after putting the simple 6 French sheet, we are going with the wire. We are putting the first proglide, and after, in fact, before the index procedure, after externalizing the two sides of the stitch, we can put again by a special hole into the proglide stem. We can put again the wire, and to put after that the second device perpendicular on a perpendicular plane of the first device. In fact, this is the step for a large bore devices when we're utilizing. You see how we are rotating first and after that the other in order to have two stitches prepared before going for the procedure. And these are the principles. These are, in fact, on such a way, the needles are crossing the artery from inside to outside, and because these needles, in fact, they are carrying the two sides of the stitch. In fact, these two sides are externalizing outside of the artery. And after finishing the procedure, we just have to, you see, to move the knot from above the artery that is waiting, let's say, 2-3 centimeters above the artery. We have to move the knot over the artery in order to make the real closure, and finally to trim the suture. So these are, and the next possibility is to use again plug-based closure device, but larger. Probably you probably know. In fact, the Manta closure device was invented by the same team like the angioseal. I'm kidding sometimes that the Manta is like a big angioseal. It's quite bigger. It's again totally absorbable. The two parts of the device are absorbable. The inner part and also the above the artery part are totally absorbable. There are two versions of the Manta closure device, 14 French and 18 French, but in fact we have used the 18 French up to 24 French large bore devices. And of course, there are many trials before imposing these devices on the market. And all this that I'm showing you are the devices that, let's say, the most proven and the biggest experience all over the world. These are the implant components I mentioned already. You see the lock above the collagen, and into the inner side is the toggle. This is in fact the anchor. Of course, there are contraindications. This is very important, by the way. For most of the closure devices, the calcium is a huge enemy. So one of the biggest contraindication for the usage of these devices is the calcium. So we need definitely high-resolution CT in order to choose a portion of the artery that will be punctured without calcium. Or we can avoid with puncturing on a different angle and to puncture the anterior wall and not the posterior and not the lateral wall, in order to have really good success. These are the steps. The steps are very similar to the steps of the angioceal. You see, this is the entrance into the artery, positioning of the toggle carrier. After putting the toggle carrier, we are externalizing the toggle, the anchor. After externalizing within the artery the toggle, we are moving behind, and after having some resistance, it means that the toggle is already on the inner surface of the anterior wall of the vessel. In this moment, we are moving ahead. The collagen, in order to the vessel wall to be between the toggle and the collagen. And this is the marker of the already implanted device. One of the small disadvantages is that in order to make a real closure, we have to remove the wire. Unlike the ProgLite, the stitch-based closure device, you remember we can stay with the wire up to the end, in which we are in the moment in which we are absolutely sure that we have efficient closure of the puncture site. In the manta, we have to remove the wire, and after removing the wire, you cannot put another device or go for another type of device. In the ProgLite, we can add another ProgLite, or even we can add angioceal. We have done several cases like this. So these are the trials, and even there is a trial comparing the large bore closure devices, which are the ProgLite, let's say the two champions, the Manta and the ProgLite. To be fair, I already mentioned that in fact the complication rate is quite similar. In the ProgLite case, sometimes we need additional steps or additional devices. In the Manta situation, let's say sometimes the complication is so big that we cannot do almost anything percutaneously. But more or less, the final success rate is very close one to each other. And also this trial is showing very similar complication rate, and quite a good success rate, and also very good satisfaction by patient's part. So this is the retrospective evaluation, and of course, the larger the device is, the more the bigger the complication rate is. And this is a very interesting trial showing, without any suspicion, that totally percutaneous approach is possible even in obese patients, and it's showing no difference in the utilization of totally percutaneous with a closure device, no difference depending, you see the body mass index, so the complication rate is, it was absolutely the same. And this is really very important, because you know that the obese patients are sometimes quite difficult for surgical approach and even for surgical correction. So this trial is very important. And this is the EVAR trial. I cannot bother you, but in fact, in all these trials, it's shown that they are applicable in different anatomical situations with a quite high success rate, and it's absolutely equipoise by complication rate. With the surgical approach. This is during the last years. In the previous years, there was several trials showing some advantage of the surgical approach regarding the complication rate. Now, the complication rate is still very slightly higher with the vascular closure devices, but in fact, the severity of the complications is much lower. The surgical complication rate is true. It's lower, but they are bigger, so they are more dangerous. So, and this is probably, and more than obvious, the vascular closure device is operator-dependent method. So we need this kind of devices to be applied by after some, let's say, training and certification. I'm showing you a complication, and this is a patient with a manta, you see, put exactly on the proper place over the femoral head. And this is the marker of the manta that is on this side. But unfortunately, there is practically full thrombosis of the common femoral artery. And what to do? In this situation, I'm coming back to the beginning of my presentation. We are using upper approach almost always, brachial or radial, because not only we can perform angiography, but we can perform, the people that are experienced with radial and brachial approach, they know that peripheral vascular interventions and vascular is possible to be done by the arm. So having this, so with a long sheet coming from the radial or from brachial artery, in this particular case is 110 centimeter long sheet, 6 French. Having this sheet just above the puncture site, we crossed the occlusion site, and after crossing the occlusion site, in most of the cases, simple balloon inflation is absolutely enough, because this balloon inflation, in fact, is putting the anchor, the toggle, over the vessel wall. So in case the toggle is perpendicular to the lumen, after inflating the balloon, the toggle is put on the vessel wall, and it's not necessary to do nothing else in order to have this very good final result. So in this situation, the balloon, in fact, helped to finish the procedure like it was prescribed properly by the company, and this is the final result. It was quite a complex suprarenal case of chimney, EVAR chimney, and this is the follow-up. You see that the artery is absolutely patent. As a take-home message, I would say that the totally percutaneous approach for endovascular aortic repair is safe and feasible. Although the success rates are higher for smaller size sheets, the successful closure may be obtained for up to 24 French. Totally percutaneous closure of EVAR, TAVI, and TAVI ensures better comfort for the patient and the same complication risk as surgical approach. And percutaneous success may result in shorter overall procedure times and potentially lower operating room costs, but this appears to be offset by the cost of the closure devices. Thank you very much for your attention.
Thank you, Ivo. I guess that we shall move this topic to the curriculum for certification in interventional cardiology. So maybe in the future, all the cardiologists should be familiar, besides all the gears and guiding and so on, also with the closure devices. It's no more luxury.
Yeah, we are dealing, cardiologists, we are dealing more and more with large bore devices. So not only for the TAVI, you know, for the structural interventions. And it's a good idea. It's absolutely, it's a necessity. It's a necessity.
Because it was a luxury, now it's something that we do on a daily basis. Mm-hmm. So I guess in the future we will have specific courses on complication after closure devices, I guess, but I hope they will be not very severe.
Your words are a good transition to the next presentation. What can be wrong? And believe me, many things can be wrong. Many things can be wrong. And our colleagues, the surgeons, are always helpful. And multidisciplinary, let's say, collaboration is very, very important. It's in interest of the patients. And we are giving the floor now to Dr. Hristo Angelov, to show us what to do in case a complication occurs.